Good evening, everyone. Today we are going to talk about acute coronary syndromes, part 2. The part 1 was discussed a couple of weeks ago. Today we will complete the entire guidelines published by American Heart Association and the American College of Cardiology. The whole recommendation based on 2025 guideline. So today we are going to talk about regional systems for STEMI care. The level of recommendation is 1. All communities should create and maintain regional systems of STEMI care that coordinate pre-hospital and hospital-based STEMI care processes with the goal of reducing total ischemic time and improving survival in patients with STEMI. So when the patient comes with the symptoms suggestive of acute coronary syndromes, they should call the number right away. In the United States, it's 911. The emergency medical services obtains EKG within 10 minutes of first medical contact. When they suspect STEMI, they should determine which hospital they should take the patient to. For some reason, whether the patient themselves go to the hospital or when there is no PCA center is available, when they go to the first medical contact to the non-PCA center, the door to EKG should be less than 10 minutes and they make a diagnosis STEMI. When they reach a PCA center, again, the door to EKG is 10 minutes. The timing is very critical in improving the survival rate. When you reach the PCA center, they should automatically activate cath lab. When they come to the PCA center, that means percutaneous coronary intervention center, directly the patient go to the cath lab bypassing the emergency department so that the delay can be averted. For some reason, there is no PCA center or the emergency medical services went to non-PCA first. Still, the need is contact the PCA center and transfer the patient there. For some reason, the non-PCA center commits to reperfusion strategy, meaning if the PCA is not feasible within 20 minutes, then the lysis, fibrinolysis should be started. That again, the goal to door to lysis should be started less than 30 minutes. The fibrinolytic therapy needs to be started less than 30 minutes in non-PCA center. If the PCA can be done within 120 minutes from the first medical contact, the ideal is activate the cath lab and transfer the patient to PCI. So the timing is very imminent. So door to device should be less than 90 minutes. If they are rerouted through the non-PCA store, less than 120 minutes, it needs to be done. For some reason, it cannot be done in 120 minutes, then fibrinolytic therapy needs to be started. Even after lysis, arrange for the immediate transfer to PCI center. If lysis failed or the patient is unstable, arrange for urgent angiography for rescue PCI. If lysis is successful and the patient is stable, arrange for early angiography. Those are all class 1 recommendations. So primary PCI in STEMI. The level 1 recommendation, patient STEMI presenting less than 12 hours after the symptom onset. The PCA should be performed with the goal of first medical contact to device activation less than 90 minutes or less than 120 minutes in patients requiring hospital transfer to improve survival. Another level 1 recommendation is in patients with acute coronary syndrome and cardiogenic shock or hemodynamic instability, emergency revascularization of culprit vessel by PCI or CABG is indicated to improve survival, irrespective of time from symptom onset. The next one is 2A recommendation in patient with STEMI presenting 12 to 24 hours after symptom. PCA is reasonable to improve the clinical outcomes. Another 2A recommendation in patients with STEMI presenting more than 24 hours after symptom onset with the presence of ongoing ischemia or life-threatening arrhythmia, PCA is reasonable to improve clinical outcomes. That means when there is a STEMI, go for PCI. So what does not benefit? In patients who are stable with STEMI, who have totally occluded infarct-related artery more than 24 hours after symptom onset and are without any evidence of ongoing ischemia or acute severe heart failure, the PCA should not be done. So this is the only one caveat. They say even stable STEMI, but there is no ongoing ischemia, the PCA should not be done. In fact, it is harmful. The recommendation for reperfusion at non-PCA capable hospitals. The level 1 recommendation is in patients with STEMI and an estimated time from first medical contact to device activation less than 120 minutes of those with a contraindication to fibrinolytic therapy transferred to PCA capable hospital. It's very important. Even though there is an option of starting a fibrinolytic therapy, but there are contraindications, those patients need to be transferred to PCA capable hospital. Another level 1 recommendation based on A-level evidence. In patients with STEMI, the symptom onset of less than 12 hours and the anticipated delay to PCI more than 120 minutes from first medical contact, fibrinolytic therapy should be administered in patients without contraindication to reduce MACE. That is major adverse cardiovascular events. Recommendation for urgent CABG surgery. This is a 2A recommendation. In patients with STEMI in whom PCA is not feasible or successful with a large area of myocardium at risk, emergency or urgent CABG surgery can be effective to improve clinical outcomes. Recommendation for reperfusion at non-PCA capable hospitals. The 2A recommendation is in patients with STEMI and symptom onset of 12 to 24 hours, transferred to a PCA capable hospital for PCA is reasonable to reduce infarct size and MACE, major adverse cardiovascular events. What is harmful is in patients with only ST segment depression, except when true posterior STEMI is suspected, fibrinolytic therapy should not be administered due to the risk of hemorrhagic stroke and major non-cerebral bleeding. So that is the only thing. When there is an ST segment depression, in the absence of ST segment elevated myocardial infarction, the fibrinolytic therapy should not be administered because the risk of hemorrhagic stroke and major non-cerebral bleeding. So what are the absolute contraindications for fibrinolytic therapy? Any prior ICH, intracranial hemorrhage, known structural cerebral vascular lesion, example, arteriovenous malformation, known malignant intracranial neoplasm, primary or metastatic, ischemic stroke within 3 months except acute ischemic stroke, suspected aortic dissection, active bleeding or bleeding diathesis excluding menses, significant closed head or facial trauma within 3 months, intracranial or intraspinal surgery within 2 months, severe uncontrolled hypertension, meaning systolic blood pressure more than 180 or diastolic blood pressure more than 110. These are the relative contraindications. History of chronic, severe, poorly controlled hypertension, significant hypertension on presentation, systolic blood pressure more than 180, diastolic more than 110. History of prior ischemic stroke, that means more than 3 months. Dementia, known intracranial pathology not covered in absolute contraindications. Traumatic or prolonged CPR, meaning more than 10 minutes. Major surgery that was done within 3 weeks. Recent internal bleeding, meaning within 2 to 4 weeks. Non-compressible vascular punctures, pregnancy, active peptic ulcer, and oral anticoagulant therapy. Recommendation for coronary angiography and PCI after fibrinolytic therapy. Class 1 recommendation: in patient with STEMI, transfer to a PCI capable center immediately after fibrinolytic therapy is recommended. Second, in patient with STEMI with suspected failed reperfusion after fibrinolytic therapy, immediate angiography with rescue PCI is recommended to reduce the risk of death or recurrent myocardial infarction. In patients with STEMI treated with fibrinolytic therapy, early angiography between 2 and 24 hours with the intent to perform PCA is recommended to reduce the rates of death or myocardial infarction. These are the recommendations for rationale and timing for routine invasive or selective invasive approach. Level 1 recommendation: in patients with non-STEMI acute coronary syndrome who are at intermediate or high risk of ischemic events, they are appropriate candidates for revascularization. An invasive approach with the intent to proceed with revascularization is recommended during hospitalization to reduce MACE. Another level 1 recommendation is in patients with non-STEMI ACS who are at low risk of ischemic events, either a routine invasive or selective invasive approach is recommended to help identify those who may require revascularization and reduce MACE. So they are a little bit liberal in recommending routine invasive versus selective invasive strategy. The timing of coronary angiography for those in whom invasive approach is planned. The first level 1 recommendation: in patients with non-STEMI acute coronary syndrome who have refractory angina or hemodynamic or electrical instability, an immediate invasive therapy with the intent to perform revascularization is indicated to reduce MACE. Next 2-year recommendation: in patients with non-STEMI ACS who are at high risk of ischemic events, it is reasonable to choose an early invasive strategy, that means within 24 hours, to reduce MACE. Next 2-year recommendation: in patients with the non-STEMI ACS who are at high risk and are intended for an invasive strategy, it is reasonable to perform angiography before the hospital discharge. This is a flow chart. The routine invasive versus selective invasive strategy in patients with non-STEMI ACS. When there is a high or intermediate risk, go ahead and start routine invasive strategy, which is a class 1 recommendation. When there is a low risk non-STEMI, still class 1 recommendation is selective invasive strategy. If there is non-invasive stratification is done, or when there is a recurrent ischemic symptoms present, go forward with routine invasive strategy. In the absence of recurrent ischemic symptoms and coronary CTA is negative, in those patients, medical therapy alone can be used. The routine invasive strategy could be PCI, CABG. If they don't find anything, medical therapy alone can be used. What are the relative contraindications for routine invasive approach in acute coronary syndrome? High risk for bleeding on dual antiplatelet therapy. Severe thrombocytopenia, meaning less than 50 platelets. Advanced kidney disease, not on dialysis. Acute renal failure. Limited life expectancy. Advanced dementia. Known coronary anatomy that precludes PCI and or CABG surgery, and patient preference. These are all the relative contraindications for a routine invasive approach in acute coronary syndrome. Choice and timing of management strategy in non-STEMI. When the patient is unstable or very high risk, meaning when the patient is on having cardiogenic shock, signs or symptoms heart failure, including new or worsening mitral regurgitation or acute pulmonary edema, refractory angina, hemodynamic or electrical instability, meaning sustained ventricular tachycardia or ventricular fibrillation, immediate invasive strategy needs to be done, which is class 1 recommendation. In high risk non-STEMI, meaning Grace risk score more than 140, steeply rising troponin levels on serial testing despite optimized medical therapy, ongoing dynamic ST segment changes, routine invasive recommended class 1 recommendation, coronary angiography needs to be done less than 24 hours, class 2A recommendation. When the patient has intermediate risk non-STEMI ACS, meaning Grace risk score of 109 to 140, absence of ongoing ischemic symptoms, stable or downtrending troponin levels. In those patients, again, class 1 recommendation is routine invasive approach. The class 2A recommendation is coronary angiography before hospital discharge. That means less than 72 hours. The fourth category is lower risk non-STEMI ACS, meaning Grace risk score less than 109, TIMI risk score less than 2, absence of ongoing ischemic symptoms, troponin level less than 99th percentile, no dynamic ST segment changes. In those patients, also they recommend routine invasive or selective invasive approach, class 1 recommendation, and coronary angiography before hospital discharge. When there is a non-invasive risk stratification during hospitalization, recurrent symptoms present, then coronary angiography, of course, if they show there is no issues, then you don't need to do that invasive approach. Recommendation for vascular access approach for PCI. In patients with acute coronary syndrome undergoing PCI, radial approach is preferred to a femoral approach to reduce bleeding, vascular complications, and death. The radial approach is preferred over femoral approach in doing PCI. Recommendation for use of aspiration thrombectomy. Among patients with STEMI undergoing PCI, manual aspiration thrombectomy should not be performed routinely prior to PCA given lack of clinical benefit. Recommendation for use of intracoronary imaging. In patients with ACS undergoing coronary stent implantation in left main artery or in complex lesions, intracoronary imaging with intravascular ultrasound or optical coherence tomography is recommended for procedural guidance to reduce ischemic events. This is a class 1 recommendation. The management of multivessel CAD in STEMI. Level 1 recommendation. In selected hemodynamically stable patients with STEMI and multivessel disease after successful PCA of the infarct-related artery, PCI of significantly stenosed non-infarct-related arteries is recommended to reduce the risk of death or myocardial infarction and improve angina-related quality of life. Another 2A recommendation in appropriate patients with STEMI and complex multivascular disease after successful PCA of the infarct-related artery, elective CABG surgery for significantly stenosed non-infarct-related arteries involving left anterior descending artery or left main disease is reasonable to reduce the risk of cardiovascular events. 2B recommendation in selected hemodynamically stable patients with STEMI and low complexity MVD, those not intended for CABG surgery, multivessel PCA of significantly stenosed non-infarct related arteries at the time of PCA may be preferred over a staged approach to reduce the risk of cardiovascular events. What is not recommended or harmful is in patients with STEMI complicated by cardiogenic shock, routine PCA of non-infarct related artery at the time of PCI should not be performed because the higher risk of death or renal failure. So when there is a complicated STEMI, just do the PCA of the culprit vessel, not the non-culprit vessel. Consideration for choice of coronary revascularization strategy for patients with non-STEMI ACS and MVD, multivessel disease. When there is a significant left main coronary stenosis with high complexity of coronary artery disease, multivessel CAD with complex or diffuse CAD, diabetes mellitus, and MVD with the involvement of LAD, left anterior descending artery, multivessel CAD or complex left main CAD with severe left ventricular dysfunction. In these patients, surgery may be preferred over multivessel PCI. The management of multivessel CAD in non-STEMI acute coronary syndrome. The level 1 recommendation in patient with the non-STEMI ACS with multivessel disease, the mode of revascularization, whether it is CABG or multivessel PCI, should be based on the disease complexity and patient comorbidities. Another level 1 recommendation in stable patient with non-STEMI ACS with multivessel disease but without left main stenosis who are not intended for CABG surgery and undergoing culprit lesion PCI, PCI of significant non-culprit lesions at the time of index procedure or a staged procedure is recommended to reduce the risk of major adverse cardiovascular events. Another 2B recommendation in patients with non-STEMI ACS in whom multivessel PCI is being considered, physiological assessment of a non-culprit stenosis may be considered to guide revascularization decisions. What is harmful is in patients with non-STEMI ACS complicated by cardiogenic shock, routine PCA of non-culprit artery at the time of index procedure should not be performed. So in a complicated patients, just do the PCA of a culprit vessel, not the non-culprit one. Recommendation for revascularization in ACS with cardiogenic shock. The level 1 recommendation in patient with acute coronary syndrome and cardiogenic shock or hemodynamic instability or emergency revascularization of culprit vessel by PCI or CABG is indicated to improve survival irrespective of the time from symptom onset. What is harmful is in patient with ACS complicated with cardiogenic shock, routine PCI of non-infarct related artery at the time of PCI should not be performed because of higher risk of death or renal failure. Mechanical cardiovascular support in patient with ACS. The recommendations are 2A recommendation, selected patient with STEMI and severe or refractory cardiogenic shock, insertion of a microaxial intravascular flow pump is reasonable to reduce death. In patients with mechanical complications of ACS, short-term, the mechanical cardiovascular support services are reasonable for hemodynamic stabilization as a bridge to surgery. So what is harmful is the routine use of intra-aortic balloon pump or veno-arterial ECMO is not recommended due to the lack of survival benefit. The routine use is not recommended, but when they are in trouble, it is the mechanical circulatory support needs to be done. The mechanical complications of acute myocardial infarction. 1. Papillary muscle rupture. They often present with acute pulmonary edema, cardiogenic shock. They can have eccentric or broad jet of severe MR, mobile mass in the left ventricle and prolapsing into left atrium. One can see ventricular septal rupture. They can be asymptomatic to circulatory collapse. They will have a left to right stent. Discontinuity of septum with evidence of color flow when you use a Doppler. Third one is contained rupture. These patients may be asymptomatic or can have chest pain or heart failure. Small neck communication to and fro blood flow through the rupture. But this blood flow, the rupture is contained. It is free wall rupture. These patients present with circulatory collapse, pericardial effusion, or cardiac tamponade. They will have electromechanical dissociation. Electrical complications. The recommendation for electrical complication and prevention of sudden cardiac death after ACS. This is a class 1 recommendation for ventricular arrhythmias. In patients with post-myocardial infarction, implantable cardioverter defibrillator ICD implantation is recommended in selected patients with an left ventricular ejection fraction less than 40%, at least 40 days post-MI and at least 90 days post-revascularization to reduce death. There is a class 1 recommendation based on level of evidence is A. The 2A recommendation in patients with post-ACS, ICD implantation is reasonable in patients with clinically relevant ventricular arrhythmias lasting more than 48 hours and within 40 days post-MI to improve survival. Another 2B recommendation in patients with early after MI, usefulness of a temporary wearable cardioverter defibrillator is uncertain in patients with a left ventricular ejection fraction less than 35% to improve survival. Recommendation for bradyarrhythmias class 1 in patients presenting with an AMI with sustained evidence of second degree Mobitz type 2 atrioventricular block, high-grade atrioventricular block, alternating bundle branch block, or third degree atrioventricular block, persistent or infranodal permanent pacing is indicated. It's class 1 recommendation based on non-randomized evidence. Left ventricular ejection fraction and the patient characteristics defining on indication for prophylactic ACD implantation for primary prevention in ischemic heart diseases. Left ventricular ejection fraction less than 30%. Oftentimes, these patients have NOHA, New York Heart Association class 1, 2, or 3. Left ventricular ejection fraction 31 to 35%. Oftentimes, they will have New York Heart Association class 2 or 3. If the ejection fraction is less than 40%, they often have inducible ventricular tachycardia. What are the clinical criteria for diagnosis of pericarditis? It can happen in patients after acute myocardial infarction. Friction pericardial rub on auscultation. Electrocardiographic evidence such as classic pure segment depression or diffusive concave ST segment elevation, or in the setting of myocardial infarction, persistent ST segment elevations or dynamic T-wave changes. New or growing pericardial effusion on echocardiography. How to treat? High-dose aspirin 500 to 1000 mg every 6 to 8 hours until symptoms improve. If you use colchicine, 0.5 to 0.6 mg once or twice a daily for 3 months. When to recommend cardiac ICU? Patient with ACS with ongoing angina, hemodynamic instability, uncontrolled arrhythmias, suboptimal reperfusion, or cardiogenic shock should be admitted to cardiovascular ICU to reduce cardiovascular events. Management of anemia in acute coronary syndrome. It's a 2B recommendation in patients with ACS and acute or chronic anemia. Blood transfusion to achieve hemoglobin level more than 10 gram per deciliter may be reasonable to reduce cardiovascular events. Recommendation for telemetry and length of stay. In patients with acute coronary syndrome, telemetry monitoring is recommended to reduce cardiovascular events with the duration determined by cardiac risk. Recommendation for non-invasive diagnostic testing prior to hospital discharge. In patients with ACS, an assessment of left ventricular ejection fraction is recommended prior to hospital discharge to gauge therapy and for risk stratification. What are the essential components of patient education? One need to explain to the patient the reason for hospitalization, explain reason for admission, diagnostic tests, and procedural results. Tailored discussion of lifestyle modification. Medications, written and verbal instructions including purpose, dose, frequency, potential adverse effects of each medication, refill instructions, changes to pre-hospital regimen, importance of adherence. Symptom management, what to monitor for and action to take should symptoms recur, including whom to call. Returning to daily routine, when to resume physical activity, sexual activity, work, and travel. Psychosocial considerations, open dialogue about symptoms of depression and anxiety. Follow-up care, future appointments with cardiology, cardiac rehab, additional testing post-discharge. Cardiac rehab. The level 1 recommendation is patient with ACS should be referred to an outpatient cardiac rehab program prior to hospital discharge to reduce death, MI, hospital readmissions, and improve functional status and quality of life. The 2A recommendation is in patient with the ACS, a home-based cardiac rehab program is a reasonable alternative to center-based cardiac rehab program to improve functional status and quality of life. The guidance for ACS discharge. Communication. The patient-centered, verbally and in writing, inpatient caregiver referral language. Shared decision-making regarding assessment of goals and preferences should be discussed with patient or caregiver. Address comorbidities and risk factors for recurrent events. Assess for presence of ongoing ischemic symptoms using standardized instrument ideally embedded into EHR. Assess risk for bleeding related to medications or procedural site. Assess need for additional testing, repeat echo, staged PCI. Assess whether vaccinations are current, for example, yearly influenza. Perform medical reconciliation, including prescription for sublingual nitroglycerin unless contraindicated. This is for patient and caregiver assessment. Assess capacity for patient and caregiver for self-care, like secondary prevention, symptom monitoring, following plan of care, lifestyle changes, contact information for continuing care team. Provide verbal and written education information related to self-care. Use teach-back method to confirm understanding of self-care. Use teach-back method for patient caregiver understanding of medication adherence and treatment regime. Confirm referral to cardiac rehab. Provide education materials related to cardiac rehab, including contact information. Social determinants of health. Assess address barriers to obtaining and taking prescribed medication to include referral to pharmacy. Assistant programs or social worker as appropriate. Assess and address barriers to attending cardiac rehab, including viability of home-based or hybrid cardiac rehab. These are the components of cardiac rehab: exercise training, patient assessment, nutrition counseling, weight management, blood pressure management, lipid management, diabetes management, tobacco cessation, psychosocial management, physical activity counseling. The recommendation for DAPT strategies in the first 12 months post-discharge. The level 1 evidence is in patients with ACS who are not at high bleeding risk. The dual antiplatelet therapy with aspirin and an oral P2Y12 inhibitor should be administered for at least 1 year to reduce major adverse cardiovascular events. Another level 1 evidence, level 1 recommendation, in patients with ACS who have tolerated dual antiplatelet therapy with ticagrelor, transition to ticagrelor monotherapy more than 1 month post-PCI is useful to reduce bleeding risk. Next, level 1 recommendation, patient at high risk of GI bleeding, a proton pump inhibitor is recommended in combination with dual antiplatelet, oral anticoagulants, or both to reduce risk of bleeding. Next is 2B recommendation in patient with the ACS undergoing PCI, de-escalation of DAPT, switching from ticagrelor or prasugrel to clopidogrel after 1 month may be reasonable to reduce bleeding risk. Another 2B recommendation in patient with the ACS undergoing PCI who are at high bleeding risk, transition to single antiplatelet therapy, aspirin or P2Y12 inhibitor after 1 month may be reasonable to reduce bleeding risk. So the default strategy in acute coronary syndrome is dual antiplatelet therapy for more than a year. That means ticagrelor or prasugrel preferred post-PCI along with the aspirin, of course. When there is a bleeding risk, there are three possibilities. Dual antiplatelet therapy, aspirin plus ticagrelor, discontinue aspirin 1 to 3 months post PCI, then single antiplatelet therapy, ticagrelor as monotherapy. These are all class 1 recommendation. Other possibilities, triple therapy, dual antiplatelet therapy plus oral anticoagulant, discontinue aspirin 1 to 4 weeks post PCI, then continue with single antiplatelet therapy plus oral anticoagulant, meaning clopidogrel monotherapy and oral anticoagulant, which is again class 1 recommendation. The third category is dual antiplatelet therapy, aspirin plus ticagrelor or prasugrel, de-escalate potency of P2Y12 inhibitor more than 1 month post PCI, then dual antiplatelet therapy, aspirin and clopidogrel. Instead of using tica and prasugrel, we use clopidogrel. This is class 2B recommendation. When there is a high bleeding risk post PCI, dual antiplatelet therapy, aspirin and P2Y12 inhibitor, stop aspirin or P2Y12 inhibitor more than 1 month post PCI, then followed with SAPT, single antiplatelet therapy, aspirin or P2Y12 inhibitor monotherapy, which is a class 2B recommendation. What are the major criteria for high bleeding risk? Anticipated use of long-term oral anticoagulants. Severe or end-stage CKD, meaning GFR is less than 30. Hemoglobin level less than 11. Spontaneous bleeding requiring hospitalization or transfusion in the past 6 months. Moderate or severe baseline thrombocytopenia, meaning platelet count less than 100. Chronic bleeding diathesis. Liver cirrhosis with portal hypertension. Active malignancy, excluding non-melanoma skin cancer within the past 12 months. Previous spontaneous intracranial hemorrhage at any time. Previous traumatic ACH within the past 12 months. Presence of brain AV malformations. Moderate or severe ischemic stroke within the past 6 months. Non-deferrable major surgery on DAPT. Recent major surgery or major trauma within 30 days before PCI. The minor criteria are age more than 75, moderate CKD meaning GFR 30 to 59, hemoglobin level 11 to 12.9 in men, in women 11 to 11.9, spontaneous bleeding requiring hospitalization or transfusion within the past 12 months not meeting the major criteria. Long-term use of oral non-steroid anti-inflammatory drug or steroids. Any ischemic stroke at any time not meeting a major criteria. These are all the criteria used for high bleeding risk. Recommendation for antiplatelet therapy in patients on anticoagulation post-discharge. In patients with ACS who require oral anticoagulant therapy, aspirin should be discontinued after 1 to 4 weeks of triple antithrombotic therapy with continued use of P2Y12 inhibitor, preferably clopidogrel, which is less efficient than tica and prasugrel, and an oral anticoagulant to reduce bleeding risk. Another class 1 recommendation for lipid levels in patients with acute coronary syndrome, fasting lipid panel is recommended 4 to 8 weeks after initiation or dose adjustment of lipid-lowering therapy to assess the response or adherence to therapy. Recommendation for use of chronic colchicine. It's a class 2B recommendation. In patients with ACS, low dose colchicine may be reasonable to reduce the risk of major adverse cardiovascular events. Recommendation for immunization. In patients with ACS without a contraindication, annual influenza vaccination is recommended to reduce the risk of death and MACE. This concludes acute coronary syndromes part 2.